So today we are going to talk about population health planning. But we're not going to just talk about population health. We're going to talk about lessons learned across an international viewpoint. These challenges about chronic disease, about planning our services and what we need to provide to our populations are global challenges. Patients are aging, they are getting more complex. There's a lot of things that are happening in our systems that we need to be able to handle and plan for, not just on a 1-year scale, on a 5-year scale, on a 10-year scale. And so we brought together this international panel. I'm really excited to have you hear what it is that they have to say. Let me just do a quick introduction for you of everybody that will be on the conversation today. Jacquie is the Deputy Director for Long-Term Care, Older People and End-of-Life Care at NHS England. We're very excited to have her. She has done a great job with managing this program in England, and she's going to share some of their best practices, some of their lessons learned, and that has actually been translated into conversation in Canada, and you will hear from Eileen Pepler, and she is an academic. She teaches in the MBA school of several major Canadian universities, and is going to bring the Canadian perspective for us today. And then, of course, you are probably all familiar with Claire Cordeau. She is the Executive Director of Healthcare for Simulate Corporation, and she has been with us for over 7 years now. And then myself, I will be facilitating today. Brittany Hagedorn, I lead the U.S. healthcare team at Simulate Corporation. So this is going to be a great discussion. Really excited to hear all of these different perspectives. And without further ado, I'm going to hand it over to Claire to get us started.
Thank you very much, Brittany, and it's been my absolute pleasure to work with these very amazing women to bring to you this international perspective on long-term conditions. I'm so pleased they've been able to join us today, and I hope you find this as fascinating and with all of its challenges as I do. So the agenda today is Eileen's going to talk to us a little bit about Canada and the UK health systems, just to give a bit of a comparison to get started. Jacquie will outline the new models of care for people living with multiple long-term conditions in NHS England, and I'll talk a bit about the simulation work that we've been doing to support that programme, and then we'll go back to Eileen again to talk about the reflections from Canada on the applicability of that programme to a Canadian population, and we then want to open this out to a wider discussion. So as Brittany says, there's a lot to get through. I just wanted to reflect about how on earth we came to be having this amazing conversation. And just really to say that Simulate's been supporting the national programme in the NHS for I think about 4 years now. It's been our pleasure to do that, and a really interesting learning journey, which we'll talk a little bit about. So myself and Jacquie White and the team know each other quite well over that period. But also, it's been my privilege to work with Dr. Pepler in Canada for I think about 7 years now, and over our collaboration, really, we've looked at a number of the issues in healthcare all over the world, and where there are lessons which could be applicable in other jurisdictions, we've shared some of that information, and it was very much this area which sparked our interest as something that we could help to collaborate to create this international conversation, which would really help both all of our learning, really, and it's been through Eileen's facilitation that we've been able to start to have conversations between England and Canada about this particular programme, and we'll talk a little bit more about that at the end. But I think we all recognise, as Brittany said, these global challenges that we have. As people live longer, they're living more with multiple long-term conditions, multimorbidity, both physical and mental, which puts a pressure on our health systems. We need to make sure that there's proper access for people, that the treatment's in place, and also our current system tends to look at curing people, not necessarily caring for them, looks at potentially body parts rather than looking at the whole person. So we've got a challenge really in the way in which we manage our health services to meet the needs of that group. And within our healthcare system, we have models that aren't necessarily reflecting the new demands that we're seeing, but also we have issues around recruitment and retention of our workforce, as our workforce is aging as well, and we need to be able to make sure that our workforce fits the needs and the support needs of the patients, the people that we're looking after. In many cases we have a fragmented system in health and in social care, and of course if you're in need of support for living with multiple chronic disease, multiple long-term conditions, then you need probably both parts of that system, and where it's fragmented it's then not difficult, it's not easy to access. And many people in this situation also suffer from exacerbations. So being able to get behind the crisis curve will help us to support them in the long term and enable them to maintain their independence for as long as possible. We'll talk around these sorts of challenges as we go through the presentation, but I think we all recognise that regardless of where we lived, actually these issues are very similar the world over. And Jacquie is going to talk about the particular solution that the NHS has been developing to this particular challenge. But before we get into that, I'm going to hand over to Eileen, who's going to talk a little bit about the Canadian and the UK healthcare systems, just to give us a bit of context and orientation. Over to you, Eileen.
Claire. Thank you, Claire, and thank everybody for coming on. It's such an important topic, and we can all learn from others who are actually on the ground implementing, and the lessons learned I think you're going to learn today are really fascinating, especially the way the UK has embraced technology-enabled care and enabled and looking at their workforce and looking at different funding models. So I think you'll enjoy the session. And the reason I was really interested in this is Canada and the UK are so similar, and Canada usually turns to the UK or Australia for looking, or the US, to look at what's new and what kinds of models of care are they starting to explore. But on this particular screen, what really struck me was that Canada has 33 million people and the UK has 66 million. But if you look at the per capita spend on health, the UK spends $29.92 and we spend $38.95. And although we're all cognizant of the expenditure, it's not really about the expenditure. It's about patients and whether or not the outcomes are achieved. The other is, as we move forward, and the real reason for looking at this is if you look at the nurses, again, nurses per 1,000, you'll see a difference between the UK and Canada. And as we look out into 2035 and we're looking at new models of care, how can we use nurses and other professionals differently? And as we move forward with new models of care, what does the workforce implications look like? So on the next screen, you'll see that Brittany is going to be speaking to a little bit at the end about the US. But then if you look at the spend on this diagram, you can see if you move from the left to the right, we have the US, we have Canada, and we have the UK. So there are definitely lessons that we could learn from other jurisdictions. And what, as we move forward, you'll recognize and see, and I'm sure all of you know this, it's really the similar challenges that we're facing. And the big one for us was, of course, the Health Accord, which expired in 2014, and the federal government's readjusting and resetting of the funding, going from 6% in the first 3 years and a minimum of 3% in the remaining 7. So now we're looking at going from 7 to 6, or from 6 to 3. And the other is in 2015 this year, of course, a number of us have had a new government, and we've got new thinking, new demands, and of course the new government's bringing their own perspective. But I guess the piece that is really important for all of us as we look forward to the 2035 and trying to achieve more services that are patient-centered is how can we move away from a non-physician-centric model. And that's not to say that physicians aren't going to be involved, but how can we begin to get people to practice and use their scopes more effectively so that people can, in fact, have access and get outcomes and begin to have their wishes heard. So we need to, from my perspective and from my learning and from what I'm hearing across the country, is we need to reset our delivery system. And reset it, if you look at the dollars on this screen, it really does say that we need to reset, we need to rethink the models, we need to rethink our workforce, and rethink the tools that we're using to look at planning strategically and then begin to link our strategic choices and our strategic models to our operations. So what does that mean, resetting? Well, resetting really means shifting to a population health from episodic or from looking at new models of care and using the new models of care as a strategic methodology, which then drives your what ifs and your workforce, and then you're allowed to test whether or not those outcomes can be achieved. It means resetting the way we look at our population shifts. So looking at over the next 10, 15, 20 years, how does our population age? How well do they age? And what is the impact of chronic disease, aging, and the social determinants of health on the wellness of our population? What's our workforce implications today and in the future? What's that look like if you change and shift to a new model of care? Because our workforce, of course, is also aging. Shifting the dynamics between patients and clinicians. And patients' voices are really beginning to take hold. Each of the jurisdictions across Canada are involved in patient engagement at looking at putting patients at the center of our models, which then can lead to better and improved self-care management. The impact of technology, and not just the electronic record, but more the impact of technology-enabled care, and of course the impact of technology as we join up the connections across the continuums. We're looking at the workforce arrangements, the demand cooperation between very different workforce groups. What does that look like? The coordinator or navigator roles will become more crucial in a complex than fragmented landscape. So if your new models of care involve community, justice, health, and education, how do we begin to coordinate or navigate across that jurisdictional health system? Thinking outside the box and keeping the welfare of the patient at the front. Learning from other jurisdictions. And how can we reset or shift to population health and test without actually looking at implementing projects or pilots? How can we begin to test in a different environment and use our technology to help us? And this is where Jacquie is going to talk about and look at the long-term conditions program, the simulation and the funding, and how they've used technology to help them get more in front of the cost curve. Over to you, Jacquie.
Thanks very much, Eileen. And again, great privilege to be here talking to everybody. I think the first thing I'd like to say is by no stretch do we think we've solved this. There's still lots more that we definitely need to do. We have, as Eileen pointed out, a lower overall spend. We have some good outcomes, but we don't have all good outcomes. So this is still a journey for us, and we're equally as keen to hear and learn from all of you and others out there who are doing things that we can replicate. So the main things I wanted to talk to you about today was about, as Eileen said, how we particularly focused on using modelling and the importance that we think that has to ensure that we look at the right things to do and the right things to do less of, and the right things to do better. We're all going through difficult times. It's really easy to retrench into individual approaches, individual organisations, and make changes that have bigger impacts on everybody without necessarily understanding that at the time. So it's really important, we've found, to have an approach that enables you to model both at a system level, at an individual, system level and strategic level, as well as an individual operational level, to really get those changes thought through and planned for and agreed that they are the right things to do. So for us in England, I'm going to go a bit back to front here. I'm going to start and talk to you about where we are now, and then go back to how we've managed to get to where we are now through the programme that Claire and Eileen mentioned, which has been a 4-year process of learning for us, and bring back into then how we've used modelling to help us do this. So for us, some of the sort of really important places we are now that we weren't 4 years ago, but again learning from us, we have a specific way now of talking about things, so the definitions and the language that we use that we think is important to get the changes that we want to happen. So we've started talking about the person rather than the patient. So we start to move away from a passive approach to care and more of a partnership. We've started talking about long-term conditions rather than chronic disease, so that we don't focus on the individual condition or the individual body part, but think about the person and what they are living with through the course of a year and their life. We've started to really focus across the whole person and their needs, not separating out a physical bit of care, a mental bit of care, and then a completely separate look at what their social and emotional needs may be, because we recognise that the whole thing is completely interdependent, and when one bit goes wrong, the rest of it goes wrong for that person. And we've started focusing more on coordinated care and how we deliver that than talking about integrated care per se, because there is certainly in the NHS, quite a fixation around integrated care, meaning structures and organisational approaches, rather than how we just shift the care to focus and coordinate around the person. So just some language points for us that we've learned has helped to move some of these things forward. In terms of some of the things that we're now tackling that 4 years ago when we started looking at some of this weren't particularly well thought through, and some of you will know the 5-year forward view in detail, I'm sure, the vision for the NHS and other system partners about how we really transform our system of care to focus very much on the person and their lives and their quality of lives through lots of changes around delivery, but also how some of the system enablers such as finances, workforce and data will be changed at the same time. So just in terms of a few of these things that we're looking at, and I won't go into the detail, we've only got a certain amount of time here, but there's more information available on all of these. We're doing a lot of work on empowering people and carers to be partners in their own care. We're understanding how to and I'm sure some of you will be very familiar with the patient activation work that's been done in the US through the Hibbard studies. So we're looking at how we can properly embed that as an approach to self-management and an approach to partnership, goal setting and care and support planning. We're supporting services to think about the whole person, as I said earlier, and linking together the physical, mental and social providers around a local neighbourhood care type team. We're strengthening the role of primary and community care to really take on their key critical role about being the home for people with long-term conditions and being the place to go to rather than waiting until crisis hits and people ending up in hospital. We're having a big focus on older people who have increasingly complex needs, including now an ability to diagnose frailty as a long-term condition and the impact of that for older people. We are, as I'm sure lots of you have seen, we're looking at lots of different versions of new care models that are looking at that wider approach to care, population-based, and we have lots of what's called vanguard, testing out different models in different areas. We are focusing on what IP can do better, including having patient online access to their own records, the ability to share records across providers, including non-traditional NHS. We're looking at workforce planning and how that could be done jointly across providers and commissioners, and how workforce could be moved to support the need rather than working in a traditional organisational boundary approach. And we're looking at what the new and emerging roles bring around differences in skills and competencies to be able to support a population, a locality-based community care model for people with long-term conditions. The main thing, though, that we wanted to talk to you today about was the approach that we've been using to look at what actually can we do to support both purchasers or commissioners of care and providers of care through a different way of understanding the population needs, understanding the current utilisation and cost of the services and how that could be delivered differently but also funded differently to really enable coordinated care to become a reality rather than being a current block in the system as it has been for a while. So that's a quick run through the various things that are happening in the NHS around long-term conditions. And a visual representation that we use is the House of Care, which is on the screen, which essentially puts into 4 components those really important things that need to be happening in a system to make all of this work. Without any one of these bits, then the house will fall down, is essentially our analogy. And the outcomes and benefits that we're starting to see that are getting people on board with a different approach to delivering care. So the next slide around the outcomes and benefits are starting to show us that if we can really focus on the person and how to support them and get them the right care, then we can see lower utilisation of services and lower costs. We're starting to see that health coaching as a particular intervention can reduce the need for emergency care and put people much more in control and seeking the support at a much earlier point. We're starting to see that medication adherence, when we actually look at the person's needs rather than just purely what the medication is there for, we're starting to see that really improve both medication adherence but also outcomes for what the medication is being prescribed for. And we're starting to see that frailty, when managed better, can also reduce the need for urgent care and can reduce the impact on social care. So it's starting to help the finance people get on board with the case for change about doing this as a whole system approach and start to be able to see how investing in some of this can yield some of the benefits. So just to pick up specifically the long-term condition zero care programme that's been mentioned, and this is, I guess, where we were 4 years ago. So lots of changes in the NHS. We've survived one political reorganisation or one organisation of the NHS. We've survived 2 elections as a result, 2 elections whilst progressing this programme. And what's been really impressive from our perspective is the commitment from the teams who started this work, but also the increasing interest and engagement from others who are absolutely bought into the need to think differently about this and the way that this can help them do that locally. So we started with this programme with a bit of a discussion about how this wasn't doable. So we started with a bit of a sort of almost accepting the challenge that people told us it was far too complicated to think about how we could pull together an approach to funding 12 months worth of care for someone with long-term conditions who needed multiple providers involved in that. So we took that challenge, we accepted the gauntlet, and we set about pretty much with these 6 areas that the teams have worked on over the last 4 years. I have to say that they're not stepwise stages, it's not linear. There has been an awful lot of learning and going back to and revising where people were at as a part of the process, because it was set up as an experiment. But we're now, we have an awful lot of knowledge about what this has told us, what it's telling us going forward, and what others might be interested in thinking about for their own populations. So the engagement and commitment across the system is fairly evident, but it has been an ongoing important step to keep people on board with this throughout the whole process and see that it isn't just a techie thing, it isn't just about data and analysts, it isn't just about money, it's about how we improve outcomes for everybody as a result of working differently. And then the next 4 stages, we've had modelling input from Simulate throughout the whole of those 4 stages to really help the teams and us understand what exactly it was that we were trying to do and what it was that could be done. So some of the learning I'll go into in terms of those 4 stages, and Claire's going to talk about in more detail the tools that sit behind what we've used and how we've gained that learning. So just to go to the next slide around the whole population analysis. What we've been able to distill as a result of this work happening and linking in with other data sources is a move from what we thought were 15 million people with long-term conditions in the UK, and that's a number that's been bandied around for about the last 6 or 7 years. We now think there are more like 27 million, and that's probably still under-recorded. We think mental health is definitely one area that's still under-recorded. We know that 10 million of those have 2 or more long-term conditions. So the multi-morbidity agenda is almost it's starting to become as big as people with one long-term condition, and starts to really push forward the agenda around supporting people rather than their individual conditions, because that just doesn't make sense in terms of efficiencies of utilisation of services, but it doesn't make sense in terms of the burden we place on people. We now know that at least 1 million people in England have frailty, as I said, as a diagnosable long-term condition, and over 500,000 we're able to see approaching end of life. We recognise that the number of comorbidities impacts on quality of life. The more you've got, the lower the quality of life. As I said, we're starting to see evidence of overtreatment and in some instances harm, because we have quite an individual approach to guidelines and use of guidelines for specific conditions that for some people can be contraindicated. And we now also know that social isolation is both a risk factor for mortality, but it's also a burden along the same lines as having another long-term condition, both for the person themselves but also for the system. So we recognise that recording and understanding social isolation is as important for health as it is for social care. On the next slide, we've got some of the impacts we're understanding on the health system. We know that on average only 4 hours a year is spent with a health professional. So by default, people are self-managing but without any particular support. We know over a third of our primary care physicians' consultations are for people with multi-morbidity, but certainly in the UK we have again an individual approach where you go with one symptom because of the timings that is generally allowed for an appointment. So the ability to help primary care think differently about how to support people at that point, we can see, and we have examples of how that impacts on the whole system as well as that person. We know that emergency bed days for older people is significantly increased, 7 million versus 1 million for the under 40. We know that frailty has a threefold increase in costs, and we know that 25% of all hospital beds are occupied by someone who's dying and probably doesn't want to be there. So those are just some of the high-level headlines that we've been able to gather as a result of this work and linking with other data sources as we've gone along. And that's helped us really think about some of the key changes that we need to help nationally, as well as the local teams understand their own population better. The multi-morbidity, just going back to that, we looked at some work that Scotland published about 3 or 4 years ago about the scale of the multi-morbidity that they were actually able to record, and we looked at how we replicated that in the UK. And this is an example from one of the teams who've looked at that exactly same approach. And what's been incredibly helpful is not only reinforcing the message about how few people have only one thing wrong with them, but it's helped people who are on specific clinics, like our cardiac consultants or our specialist heart failure nurses, think about the fact that even though that person is there for their heart, there are a lot of other things going on that might be impacting on their heart, the management of their heart condition, or on them as a person. So it's helping other clinicians who don't necessarily see that broader picture think about how that person's care needs to be approached and what other things can be linked in. We've also looked at the approach around multi-morbidity and the driver of how that drives cost in the system. So what we've been able to identify is the number of long-term conditions is the strongest driver and is the more stable predictor of cost than any other way to segment the population. It helps us understand the utilisation, current utilisation, and really think about how to redesign that utilisation to get better outcomes, but at also better value. We have been using that, and the teams that we've been working with have been using that to select the cohorts that they are looking to support differently and track the data over the last 3 to 4 years to see how that impacts over time. Next slide, please, Claire. And what we've also been able to demonstrate is a crisis curve. So what we've recognised is most of the risk predicting tools have focused very much on people who are at risk within the next 12 months of a hospital admission in the UK, in the NHS. And actually what we know is that that's too late. We need to be able to get to the people before they hit that risk prediction tool so that we can put the right support in to enable that crisis curve not to happen for those people. So the crisis curve has been able to be produced because we've tracked data over time. We've also, there is a way of comparing, looked at the risk scores using risk tools and the number of long-term conditions, the multi-morbidity tools, to just see what difference there is. And whilst both predict the crisis curve, again what we found, which reinforces the previous slide, is that the number of long-term conditions is a more stable predictor of who the people are that need support rather than waiting until they hit a risk tool. So that's one of the reasons why we're focusing on how we can use the number of long-term conditions to drive the changes that we're after. So next slide touches on, as a result of that and understanding the data, what the services are, the service bundle, if you like, that have been pulled together as a result of all of this. And again, through the modelling work that Claire will talk about, we've looked at the current versus the future potential delivery of these types of services. So within the approach to this different way of working, the different way of buying and providing care, we've got a red bundle, which we're already able to, within our current legislation and our current legal framework, pull together into one approach to being able to purchase care and one approach to being able to pool money and fund it. We're also wanting to move to the green bundle so that that's the stuff we'd like to see happen within time, but we can't do everywhere yet because of the different legislation and frameworks, etc. But ultimately, what the data has told us, that you can put all of the red and all of the green together and have a fairly stable approach to being able to predict and plan the care that's needed and being able to fund it with some risk and reward arrangements built into that. The purple are stuff that is definitely out, and that's a very high volume, needs much bigger population to be able to buy and provide that care. And so the last slide that I just wanted to touch on is so what is that telling us in terms of what differences it's making? Well, the data, the understanding of the services, the providers working together to think about how that can be done differently, have basically led to different delivery models, but with some key similarities. So some of the similarities are around the real need for a single point of access, the key enabler around care planning, supported self-management as an intervention, coordination of care for people rather than expecting them to do all of that themselves, having that multidisciplinary team based around GPs, primary care physicians and the communities and the neighbourhoods they live in, the recovery, reablement and rehabilitation service, which we'll touch on in Claire's next bit, and then bringing in for us the voluntary sector and the use of care navigators to support some of that social element and bringing people into their own community to engage much more around the social isolation agenda. Some of the differences have depended on local populations, whether people have different types of organisations, and what else is going on that this is needed to be brought into and part of. So differences are obviously there, and this isn't a one-size-fits-all, but some of the similarities have been quite key and reflect a lot of the evidence around what great long-term conditions care should include. So that is all I want to say for now, and I'll hand over to Claire.
Jacquie, thank you so much for that really helpful overview of the programme. And what I want to talk about is how we've been using simulation to support that programme in a number of different ways. And the first thing I want to talk about, Jacquie mentioned using simulation for all sorts of different types of decisions, and this particular type of decision is really at the strategic level. For people not so familiar with simulation, what we're doing here is able to model the system in a virtual environment on a computer, and the benefit of that is that it allows you to ask some of the questions around these complex changes in system that you need to bring about in order to provide really good care for people living with multiple long-term conditions. And so it's a useful system to do that, because obviously it takes the risk away from putting that change in place in the real system before you've worked out that it's actually going to work or not. So in this particular case I'm going to talk about, this was a strategic decision where the site, looking at it, wanted to look at the impact of changing demographics on their patient journey, and looking particularly as a group that would need additional support that Jackie's been talking about, and they wanted to look at that whole system view. So they wanted to go right across health and social care, right from the first point of contact. So they used our tool Scenario Generator to do that, and what that enables them to do is to take their age-banded population and multiply it by age-banded disease prevalence, and that's an HIV example there, to get a sense of demand from the particular population. So it's an easy way of associating your population health and the likely trajectory, the likely demand, with what you're expecting to come into your system and the services that you need to provide. And what they did was to put that calculation into the scenario generator, which allows them then to model multiple pathways of care and look at the costs and resource required, and ask a number of the what-if scenario questions that will help them test out whether changes and improvements are really going to have the desired outcome. So this example comes from North Staffordshire and Stoke-on-Trent, and their question was, what does current unscheduled care flow actually look like? They wanted to understand that better, and if they only took into account the ageing population, what's it likely to look like in 5 years with the increasing complexity? And if they increase the referrals to home care direct from hospital, in the current situation they had a number of people that went into community hospitals or who were staying in hospital, what would that mean? What would the cost be? What would be the resource requirement in order to manage that? So that was their question. They built a lovely complex model. We're talking about a really complicated system here, so I don't think any of you will be surprised to see that level of complexity, and you can see the numbers on the screen there. But essentially what it's tracing is the first point of contact with the system, right through all the different ways in which you might access emergency care. This is the hospital part here, and this is the part where they either go out to a community hospital or to a variety of different social care providers. And the first thing to do was to make sure that the simulation was representing what was happening in real life. So they validated the simulation, and these are the numbers under Scenario Generator, with the actual NHS data to make sure that they were getting a reasonable result, and they felt confident that actually it was producing a reasonable replication of their current system. And they also put in the cost and length of stay assumptions, so you can see the cost for hospital and community beds, and for they had a number of different social care interventions in there, and also the length of stay within beds, because they wanted to look at the capacity that would be, of bed capacity that would be used if they made that change. So you can see the results are showing here that with the population increase over the next 5 years, you can start to see how demand's going to increase in emergency care, and what that means for the emergency department and emergency admissions over the next 9 years, which is around about 5% increase, and also the knock-on impact on home care. So the scenario, the what-if scenario that they wanted to test was what happens if we put in increasing home care. At the moment, a lot of referrals are going straight out to the community hospital, which actually people were staying in quite a long period of time, around 21 days, when in fact they perhaps could have been moved out to with a supportive package in order to enable them to stay at home a bit longer. So they looked at the sorts of packages of social care that people who were being referred directly were getting, and then said, well, what would happen if 30% of those people who are now going to the community hospital actually go to a home care arrangement? Let's say, and erring on the side of caution, let's say that that group are going to spend an additional 2 days in hospital because it'll take us a while to set up that package and we'll need to put the assessment in place. So there might be a knock-on impact on the inpatient beds in the hospital. And let's say that about 10% of those referrals are complex cases, 38% are sort of maintenance, and 51% are reablement services. And so here are the results. What they saw was that there would be a 2.6 million savings overall, which is was a good result for all the things that they wanted to put in place. But big surprise, £4 million was going to have to be found by social care in order to provide that service. And in fact, the savings would be accrued by the healthcare system because the utilisation of the community hospitals would be reduced, and they could see what that would mean for their maximum bed occupancy. They could also see that actually they would have an additional 1.3 million cost because of additional length of stay in the hospital and how that would impact on the maximum bed occupancy. But with some of the savings they were going to accrue within the system, of course, that could be managed. Now, you can imagine when those results come out and you take them to a set of stakeholders, how different parties might feel about where those costs are going to fall and where the savings are going to be made. But as Jacquie was outlining, the whole point of having a capitated budget with a service bundle which is based around individuals is to enable some of those savings to be shared and to be associated with a person, so that individual organisations providing that care are recompensed for what they're doing. They're able to build their capacity, reduce the capacity where they need in order to ensure that the care is in the right place for the individual person. So in this particular case, the simulation was used in order to build the strategic case for what this might look like, to get the engagement of the different partners in that change and to get buy-in for moving forward with that, and make sure that the financial flows reflected the patient pathway. So that's the first example I wanted to share with you. The second one is the simulation, which is actually available online through NHS England for the year of care. Now, this has very much been following the evolution of the year of care programme, and it was produced both to help inform decisions over those 4 years, but also to disseminate how people have been managing the implementation of the year of care approach. And the way that the model is set up reflects the programme. So it's looking at a typical person, let's say, with 1 to 2 long-term conditions. They're reasonably independent, but they're accessing a whole range of different services, from hospital services to care services to mental health services and support within the community. Now, one of the things that the programme was able to indicate was the proportion of people who were likely to access those services in a year, which then enables us to plan what services need to be in place and what capacity needs to be in place. So this is the kind of pathway for somebody who's not at the most acute stage, but is still going to need those services. And when we looked at the data, what we could see that obviously over time people do start to develop more long-term conditions, as Jacquie showed in that multimorbidity graph, and therefore they're going to need the same services, but they're going to need them in different proportions. So you can now see that of this group, 56% of this group at a high level of acuity are likely to access the emergency department. 40% are likely to access the need a hospital bed as an admission. So because this is the way that we understood the cohorts of patients and the way in which they were using services through the national programme, we were able to replicate this in a simulation so that a number of different local sites all over the country could use those same different assumptions and could put in their own data to see what the impact would be if they implemented this kind of system. So this is a simulation, and you can see that we've grouped patients in a number of different types of groups based on their acuity, and at a local level people can decide what that is. But of course we're accounting for the fact that they transition between those different states. And as the previous images show, if you transition from state to state, you're likely to have a different package of service with a different level of frequency, and that of course has a knock-on impact on the costs that accrue for that particular person or those same group of patients, and also give an indication to the health and care system what capacity they need to put in place in order to make sure that those services are available. Now, the real purpose of the simulation is to help systems understand what would be the likely capitated budget, the likely sum that you would need to assign to each patient in those different groups, and was there some sort of coherence between those individual patients, so you could say, yes, well, typically somebody in that medium group would probably need about £10,000 in order to be able for us to meet their care needs over that particular year. And it allows you then to simulate the types of services that you would need in order to produce those kind of results for planning purposes. And the sorts of results that you can see is that this is the number of patients across the simulation over a number of years, the cost per patient, so you can start to set that capitated budget, and how that compares with the cost within your system. And you can drill down into the emergency department, so you can see the resources that you would need, for example, the level of activity and the costs. And you can go across the model and look at any service that you like in order to get that kind of resource to help you, result in order to help you plan. And then lastly, I wanted to very quickly show the rehabilitation model, which is looking at how patients move from the acute phase of their care in a hospital to the rehabilitation phase, so that we can see the bed utilisation, but also if we were to move people into a rehabilitation phase when they were no longer needed to be looked after by a physician, what sort of capacity we would need in order to do that. Now, there was a lot of work that went on in this area, but I'm just going to very quickly flick to the simulation so you can see what this looks like. So I'm just running the simulation through here, and what this is showing is the number of beds available, and it's allowing people to see if they were to change the length of stay in a hospital and have a proportion of that length of stay in a recovery facility or at home with support, what's the likely impact on costs, what's the impact on capacity, and how would that work. Now, most hospitals were not collecting the data the point at which a patient no longer needed a physician and the point at which they could be looked after by a rehabilitation nurse. And so they used the simulation, they still do, to look at some of those sorts of results in order to help with the planning where the data has not been available. So I hope that's given you a brief view of how we've been using simulation to support the programme. And I'm just going to move over now to Eileen, who can talk about how she's been applying some of this learning and thinking in Canada. Eileen, over to you.
And before we get into the lessons and applicability to Canada, can I ask you, Claire, to go back to your diagram of the RRR model? That one. This one really has stuck with me and is such an important simulation as we begin to look at ALC beds and we look at people transitioning between the facilities, long-term care, residential homes, supportive care, and the acute care. And this diagram is really important as we look at people who have falls or people that needing to go into acute care because of UDIs or whatever. And as you see on the left where it says the pre-admission community phase, what if, and this is where we start to get into what if if the person leaving the facility being transported into the acute care, what if we had an common agreement between the baseline going in and we understood where that person needed to be in order to get them in, and what if we knew prior to the person going in whether or not it was going to be a rehab bed or whether they were going to be transitioned to a different type of facility. So this model is really, really important as we start to look at new models of care for people going in and out of rehab or recovery and staying in their own home, and what does that allow us to start to test. Thank you, Claire. So in Canada, we have, as Claire said, next slide is we've been working for the last 7 years trying to introduce a new concept called scenario planning and starting to get people to test their what if and to shift the focus from operations to really to strategy, and looking at strategy driving the service delivery as opposed to the other way around. And so scenario planning, we've had very good luck and have been very successful in introducing it into a number of provinces. And it certainly allows us to take a what if and to test our new models of care without investing in projects and without harming patients. But you can see that on the right-hand side, it really, truly does allow you to take a long view over time, and it also helps you to identify the triggers, and it helps you to gain consensus collaboratively with a group. And I've used this with using simulation with a group of physicians and tested their view and what their view would look like on the system. Next. So again, as Claire said, really looking at what is the impact of whole system change and what is the workforce implications. And if we talked about mental health, and what does that look like? What can new models of care look like? What if we brought in peer coaching? What if we brought in technology enabled so that young people could actually begin to have their counseling sessions from their iPhones? So what if? So we started to look at, as Claire talked about, the demand from the age, and you can see here that we've used it also with a group out of Alberta who are interested, and this is a really interesting one, is for people who are overweight or obese. And every day we see and hear about the obesity or overweight problem. And they're starting to look at what can we do to get in front of the cost curve or get in front of the prevention. So my suggestion in working with the group on obesity and overweightness and diabetes is what if we were to actually simulate over the next 5 to 10 years the status quo. So let's say we don't do anything. And in 2015, we have 1,732,000 people in Alberta out of 4 million who are considered overweight or obese. So if we don't do anything as of today until 2025, what does our population look like, and what does it do to downstream, bone and joint? What does it do to depression? What resources are going to be consumed from pain? What resources are going to be consumed from unemployment insurance or disability, because people are going to have to stop working for a while if they're truck drivers? So again, it's what if, and using this predictive analytics to really begin to say what do we really need to focus on and what are some of the new models. Thank you. Next. So you can see that the questions that we started the dialogue with this group was, how many children aged 1 to 15 with complex needs may need access to primary and pediatric services? What impact do different care stage durations have on cost? And how do people who now have 1 actually get to 3? Because they say that if you are overweight or obese, there are 22 conditions, chronic conditions linked to obesity. So what will that look like in 2020 and 2025? And more importantly, what is the impact on our workforce and our services and wait times? So what percentage of the population with type 2 have access? You can see the different what-if questions, but number 4 was really the important one if you want to put your business case together to create awareness of what obesity does downstream. Thank you. So just to very quickly, in 2010, or 2011, we worked with an organization in Ontario to test non-funded maternity cares to immigrant and refugee women. And so we started to look here at the long-term vision of partnerships between the different groups downtown for delivering immigrant and refugee care services. We wanted to look at creating a critical decision path for choosing what are some of our strategic options in order to ensure that immigrant and refugee women receive the right care in a timely way. And it also allowed us to look at a path that accounted for and adjusted for changing federal government regulations. So very quickly, it was a very successful project. It highlighted the need to look at addressing funding issues, and it encouraged a physician collaboration across the system. Next, it was a project that we looked at, which was very exciting for me, was linking food banks to chronic disease. And this was another Ontario project where we had a food bank across the street from a major hospital. We had it next door to a community center, and also folks from the food bank were using 3 or 4 of the major emergency departments for their services. And so bringing together the city, bringing together 2 major hospitals, a community center, and a couple of food banks, we wanted to look at what would a new model of care look like, and how can we begin to implement prevention services as opposed to waiting for people who have to go to the food bank to become increasingly at risk of diabetes and overweight as a result of the food they were eating. So again, this one here was a demonstration. We used Scenario Generator. We took the population projections. We looked at the age-related. We looked at the immigration and ethnic factors. We included the income, so the whole social determinants of health. We looked at the moving out, the increased people that would be accessing food banks, took into consideration what the Canada Conference Board said about food security and access to food. And the next picture will show you exactly that when you think about linking food banks to chronic disease. Next picture, next slide. Hello? Yeah. Is you can see here that when we were looking at linking the food banks, we really were interested in what are the modifiable factors. So that was the focus of this project. Next. The one solution and one scenario that we did come up with was we tested a nurse practitioner-led clinic. And you can see here that this particular scenario, I actually highlighted people coming from the food bank going into the nurse practitioner clinic and eliminating the need for the emergency department. Next. This is a high-level concept picture, and it shows the food bank. So we had the family health team from the major hospital across the road from the food bank, and we had the Mount Sinai academic health team look at co-locating in the community sports center, the community center, and people from the food bank, clients of the food bank, if they were detected as having a mental, some of the health issues, they would be given a referral over to the nurse practitioner-led clinic. They would see the nurse who would then manage, and the family health team would so it's really a truly primary care service hub. And in this particular case, some of the referrals were for physical activity and recreational access to the community center versus a medication prescription. Okay, next. So again, very quickly, this was a one for children and youth mental health. Again, across southwestern Ontario, we were interested in taking a region, a very strategic look, a helicopter view of how children and their families access mental health and addiction services across southwestern Ontario, and we were interested in looking at the fragmentation, the duplication of resources and services, and looking to see whether or not there were new ways of delivering services to improve access, reduce the fragmentation, the bottlenecks, the handoffs, and look at information sharing cross-sector between health, justice, education, and social services. Next. We highlighted, this is just a particular diagram, a scenario from a simulation of a referral. And you can see here the total cost of just one referral for the number of referrals in this one agency. And if they did nothing, each referral would continue to cost $14,000. And you can see here that referral was seen, and the way in which we operated and we worked and functioned, the referral was seen as a true bottleneck to getting access to the service. Next. Just a screenshot of the simulation results here. You can begin to see that the intake process timings, and you can see the individual steps of trying to get just right into the service. So just the intake process, the initial assessment timings, and what we found fascinating was the assessment meetings, 67.5 minutes, so an hour and a half for every. So you can begin to see with these results that we really needed to look at simulating and working differently. And if you look at the bottom right-hand side, you'll see discharge, transition, and follow-up. If you add up all those minutes, it really truly does show that there is an opportunity to reset and rethink the way we work. Okay. So some of the potential opportunities that came out of this particular work, and this work is available on www.kidsjourney.ca, the entire findings and the methodology and the tools, and the different collaborative approaches we use to get at what are some of the possible solutions, and the buy-in from across the system, which led to 5 distinct opportunities, which 2 have been implemented. So you can begin to see the individual steps in your process and some of the possible solutions and the benefits. Next. Also, the simulations showed, I don't call them cost savings, I call them cost reinvestments back into the system to enable us to be able to improve the service, change the way we work, and also improve access. So it's really cost avoidance. Next is another, so I'm turning it over now to Brittany. Thank you, Brittany.
Yes, thank you, Eileen. This has been a really fantastic discussion. I am so glad that we've been able to have this, this panel together today. I want to just reflect very briefly about how this is very actually similar to the U.S. challenges that we face as well, and the applicability of this. For those of you who are coming at this from a U.S. perspective, you saw very early on, Eileen pointed out, there was a chart that had all of the expenditures per capita, and the U.S. was almost double of the Canadian and UK dollars. So while Canada certainly has opportunities, as Eileen has talked about, and the UK is continuing to improve, we have a much larger gap to close. And there's a lot of different reasons that may be. Part of it is our public-private system and how that impacts how we manage things. But actually the largest expenditure is hospitalizations, right, the inpatient stays. And those are some of the things that we're talking about avoiding, right, in both the UK and the Canadian examples that we've just heard about. And the challenges are the same, right? How do we transform our system? How do we make this non-physician-centric? How do we think about the payments and the incentives and the workforce and putting all of these solutions into practice? There's a ton of opportunity. I think the one thing I do want to point out as well is the great results that we heard about from Jacquie. 8%, 12%, 30% savings that they've been able to achieve in readmissions and costs and hospitalizations and a variety of other key metrics. And this is just a fantastic set of results. And I really think it's important that we start thinking about how we learn from some of these lessons. And you know, as we are setting up our ACOs and our patient-centered medical homes, and we're starting to change the way we contract, these are all going to be important lessons for us because we're starting to work in a very similar kind of environment, and maybe we can speed that innovation process along. There are a couple of questions that have come in, but before we get to those, I just want to ask everybody, Jacquie, can you start us off? One sentence, what is some of the key learnings and what is your key takeaway from today?
So a lot of international brains are better than one set of national brains. We're all grappling with the same sort of problems. Some of us are doing things different, some others are doing things in a more advanced way, and we could all learn so much by trying to do it together rather than individually.
Thanks. Claire, do you have a thought?
Just how, despite the differences between our jurisdictions, how very similar the questions are. And I think what's been interesting in Canada has been the focus on the workforce and workforce planning, and also the application of the sorts of things that Jacquie and the team are doing to pediatrics, children, young people, and mental health.
Great, thank you. And Eileen, do you have a thought?
Yeah, I do. I was going to say thank you very much for facilitating. Thank you for putting this together. The learning for me has been we're working with Alberta and with a great team in Alberta who have embraced the learnings that we've heard today and are starting to look at the what if and the workforce implications using the model of care approach. So it is exciting, and I think that the lessons is that there is no better tipping point than today, because we really do need to bring and look at new tools and look at strategy and how we're going to move forward, especially in today's economy. Thank you for doing this today.